Well, welcome back. We drive straight into our health matters this evening. Now, Dr. David Emvula, a specialist obstetrician and gynecologist, recently presented at the Namibia Health Exhibition on the critical topic of infertility, particularly its connection to endometriosis. His insight shed light on the complexities of this condition, which affects a significant number of women and can lead to infertility. He now joins us, of course, to unpack this topic. Doctor, good evening.
Good evening. I'm happy to have you here.
Thank you so much for being here this evening. Very interesting and perhaps some would say, sensitive topic, the topic of infertility, but I want us to be as educated as possible this evening. I want to talk about perhaps the main points that you highlighted in relation to infertility and endometriosis through this presentation that you gave.
Yes, I was very excited to have been invited to be one of the presenters at the recently concluded Namibia Health Exhibition this weekend. And one of the issues that I highlighted was issues related to infertility in Namibia, specifically looking at the navigating the challenges that we are experiencing, and we are seeking solutions. And we really highlighted and unpacked the causes of infertility, and specifically highlighting the different gender types, such as from the males to the females. And one of the issues that we see related to female infertility is endometriosis, and we're really trying to highlight and try to educate as much as we can, so that we try to diagnose and also where we can prevent the dangers or the consequences that comes with conditions such as endometriosis.
When you speak of the challenges in relation to Namibia specifically, what are those? What do they look like, Doctor?
So the issues with the challenges is that one is that our prevalence rate or the incidence of infertility is underreported, and it's up to us as clinicians to do more research and to publish and really put out the data there on the current status. So there is literally limited data in terms of the current. But when it comes now to the challenges, it's mainly related to the to diagnosis. Once we make the diagnosis of infertility, especially in the public sector, there is nothing much we can offer, as we know that we do not have assisted reproductive technologies available in the public sector. The other issue that we also highlight is that issues related to although we know that there is assisted reproductive technology to treat infertility available in the private sector, but that comes at a cost. And the question that we need to ask ourselves as a country is, why is infertility not being treated like a disease like any other diseases, specifically with the issue of the medical insurance or the medical aids? Why are they not covering treatment for these patients? Because they don't choose to have infertility. They have condition or diseases such as endometriosis, that is, anyone is prone to develop this condition. It's not like they chose to have this condition. Patients have premature ovarian insufficiency, where their eggs just finishes prematurely at a younger age, or for other conditions such as Turner syndrome. They don't choose to have this. And the question that we ask ourselves is, why are they not catered for? And the only solution is to have this done privately at a very, very, very high expenses. So we need to find out measures to mitigate the costs and see how we can help these patients that also have a right to have a child or a family like any other person.
In Namibia, if you know, perhaps you have some statistics at the top of your head that you can share, but how many women percentage-wise, or one out of how many women, one out of how many men are affected by infertility?
So we must look at the global. We know that infertility is not a Namibian problem, it's a global problem. And what is reported statistically globally, it is that 1 out of 6 couples are affected by infertility, meaning that if you have couples, 10 out of 10 couples, 6 out of those couples are having difficulty in conceiving. And that's quite a significant number if you look at it. And although we do not have really the true data in Namibia, we believe that we are also upright there with that global data. And what we also see in actual context, global data is 1 out of 6. But if you come to developing countries, and when you speak about developing countries, it's mainly Africa, specifically in the sub-Saharan Africa and Asia. That number reduces to 1 in 4. In other words, it's almost 25%, which is even more worse, meaning that we see more and more patients. And perhaps in Namibia, if you were to thumbs up that that number is probably between 1 in 6 to, 1 in 4 to 1 in 6, which is quite a significant number. I don't think we are not far from that number, and I hope going forward we want to do more research and really come up with a true prevalence of the condition in Namibia.
I want to talk about contributing factors, and I think when we speak on women, of course, endometriosis is right at the top of that list. But before we get into what are the contributing factors for women that leads to infertility, let's look at our male counterparts, because I think that's a conversation that's not often heard. Infertility within men. What are the contributing factors, or the leading contributing factors for men when it comes to infertility?
Yeah, so most definitely, when it comes to infertility in terms of the distribution in the causes, there is an equal distribution between males and females, and that is reported to be about 30% in both of these males and females. However, we know that the burden of the disease is usually borne by the women, mainly because it is believed that males are to be infertile, especially in the society, but that is not really true. And when it comes to the etiology, when it comes to male infertility, it's quite puzzling that we really do not really have it's not similar to females where we know specific causes. However, we know that lifestyle does play a role, specifically smoking, whether it is cigarette smoking or illicit drugs. Alcohol does play a role. Using of tight pants that pushes down the testicles closer to the body compared to using loose pants where the testes are hanging away from the body, because naturally they are meant to hang away, and it is for the role of as a way of forming sperm. So all these are some of the lifestyle mechanisms that contribute, but all we see when we do most of the analysis is that what we see is a poor semen analysis. In other words, you either have a reduced number of sperms, you need a lot of sperms to fertilize an egg, or those sperms, if they are there, they are not moving to reach the area where the fertilization happens, or if they are there, sometimes they are not of normal. So most of and also weight, by the way, also plays a role. Overweight does play a role. So those are some of the most of the challenges that we see with lifestyle, and most of the time, if we ask patients to do lifestyle modification, it does improve their semen quality and subsequently enable them to conceive. So it's all depends on the cause, but those are some of the most common causes.
On to women, of course, endometriosis, as I mentioned, is probably the #1 contributing factor. I want to talk about other contributing factors as well. But starting with endometriosis, doctor, break down how endometriosis, contributes to infertility.
Yeah. Endometriosis is one of those puzzling diseases in gynecology, mainly because we do not really understand the true etiology in other words, how does the disease develop? We understand that the pathophysiology that we know, the tubes are open in the abdomen, and every time when a woman goes to their periods, there is part of the wall of the uterus that breaks down with the menstruation on a monthly basis, going inside into the abdomen, and with that going into the abdomen, it then starts growing outside. That is what endometriosis is. The question that we ask ourselves is that this happens to every woman, but why only a certain women develops it? We still don't have answers to that, and it does affect fertility in 3 aspects. One is that naturally, if you have endometriosis, because it creates what we call a hostile environment, which is somehow chronically inflammation, and that #1, it affects the ovaries, meaning that if women are born with a finite number of eggs, meaning that whatever you are born with, it is that fixed number, and it will go down every year. So with that finite number, we see that those patients, their eggs depletes faster than average women population. That's one of the contributing factors. The second one is that it is that hostility environment. It is toxic to the sperm, it is toxic to the eggs, and does affect fertility, so there will be no fertilization. The other one that we see most commonly is the tubes. It does damage the tubes, and with the damage of the tubes, there is no any places for the eggs and the sperm to meet for fertilization to happen. So those are the 3 main different pathogenesis, how it really contributes to infertility.
Other than endometriosis, what other issues could lead a woman to be infertile?
So there's many factors, and specifically the one that is not well spoken of, and is also the leading cause of infertility in the developing countries, is a role of sexually transmitted infections. We know we always speak about using contraception,
Right.
but we mainly focus on medical contraception. We don't speak about barrier, and there is the sexually transmitted infections is on the rise, and we are seeing more and more women that are having sexually transmitted infections, and that is the leading cause of infertility in sub-Saharan Africa.
Wow.
It is sexually transmitted, specifically a bacteria called chlamydia and then gonorrhea. They damage the tubes, and that is the leading cause of why most women have infertility. The other ones that we are also seeing, and it's very interesting, I also highlighted this data at the recent conference, is that we did a small study analysis at our Katutura settings in the state sector, where we found that the leading cause of infertility there was tubes. But when a private clinic did an analysis of their leading cause, they found that it is anovulation. In other words, they do not ovulate, and that relates to lifestyle, and especially their weight. Weight does play a role, and it prevents women from ovulating, and if you don't ovulate, you don't fall, you don't get pregnant. And
Right.
that contrast difference in terms of those findings is that we know that in the public sector we deal with patients from the low economic, socio-economic status, and there is a lot of this risk of sexually transmitted infections compared to the other private sector, where we found that most of those people, it's a lifestyle issue. These patients are usually obese, they are overweight, and all these things. It's very common. So those are the most some of the other leading causes. And then the other ones can be genetic, where your eggs finishes earlier than expected, and many other factors. But those are the most common leading ones.
Doctor, what are some of the most common misconceptions that, you know, communities have when it comes to the issue of endometriosis and infertility?
So when it comes to endometriosis, I think I would probably say it's specifically to us as healthcare practitioners, is that we are not diagnosing this condition, number one, enough patients, and we see a lot. I recently saw a young patient who has been having menstruation periods since the age of 17. She's now 27, and she has been being managed as painful periods, and we want to especially advise and remind our colleagues and also patients themselves that if you have painful periods, there is a high chance that you are most likely having endometriosis, and you need to be assessed. And the issue is that the earlier you are diagnosed, the earlier we are likely to give you some at least hormonal treatment that can prevent the progression of the disease to a stage where the damage has been done, such as tubes, and your ovaries are already having reduced number of eggs. And at least that will help us in terms of preventing and keeping down the infertility rates that we see with these patients.
Yeah. There's obviously no cure for this, doctor, just a treatment plan.
It's mainly, it's a condition that we manage the condition, and the main things that are associated with this, number one is pain. It's a painful condition. Patients complain of pain, so it's mainly pain medication. The other one, if they need fertility and they are struggling, we can then do assisted reproductive technologies for these patients. So it's mainly, there's no cure, and we manage the condition, and depending on the needs of the patient.
Is there a spectrum on the endometriosis scale where, for example, you're between 1 and 3, you still have the possibility of conceiving, you know, between 4 and 6, the chances get lower? Is there a spectrum to this?
Yes, most definitely. And yes, that's very important to highlight. It's actually a weird disease in a sense that you find someone with endometriosis. There's at least 3 different types of endometriosis that are developed. One is just some small deposits that are just inside. Some are having what we call deep infiltrating, which almost behaves like cancer. It goes into other organs, and it's quite messy. And those are the ones that we see with those tubes that are damaged, and the environment is more hostile compared to the other. And then the other one is the one that affects specifically the ovary, where the ovary will find a big cyst, and then that also damages the eggs and all that. So it all depends on the type of the disease that you have, and you find that those patients that have tubes that are fine, they are having what we call superficial type of endometriosis. They may not really have issues with fertility, but those ones that have the deep infiltrating type of endometriosis, or those big ovarian endometriomas, those are the group of patients that you usually see struggle with infertility. So it is not unusual. That it doesn't mean that if you have endometriosis it equals to infertility. That also needs to be clear out there to the general public.
And of course, doctor, not everybody who has this issue of endometriosis would, you know, go the conventional route of going to a modern day doctor to seek treatment, etc. Some turn to traditional medicines, etc. What are the dangers in doing that?
Yes, I mean, what we see with this type of disease, the challenge is that the truth that we see is that it is pain. And, you can have sometimes the best imaging in that we have available in the medical space, such as the CT scan, MRI, and you may not pick up that those deposits that we may see at surgery if we do a laparoscopy. So you may now find that you go to a doctor, you do all these scans, the doctor explains to you, by the way, there's nothing on these scans and we can't explain your pain, but the patient is going through the pain, and then that's when perhaps your question comes in. So we just want to highlight that if you really have that and you've been assessed, perhaps you must still seek a gynecologist's opinion, and that is where the role of surgery comes in. And then those are the patients that we may then advise to do a diagnostic laparoscopy, but even more so, a diagnostic laparoscopy should be someone with experience, because you put in a camera and you are not looking for those specific signs that are suggestive, because sometimes they are very subtle and you might not pick it up easily. So it's all about that. You need to seek an advice from a well-experienced surgeon when it comes to endometriosis.
Yeah. Just lastly, Dr. Emvula, are there any new advancements in research or treatments for endometriosis that you've
Yes,
seen?
yes, indeed. One of there is specific drugs that we know that they're really very good for alleviating, number one, the pain, especially with endometriosis, especially those drugs that are known as gonadotropin releasing analogs. But the problem with those drugs, you cannot use them for a longer period, such as they're not recommended beyond 6 months, because they then give you what we call menopause symptoms. So they are only limited so that. So there is newer developments of drugs such as elagolix that have been coming out, the gonadotropin releasing hormone antagonist, that they are showing research that we can give these drugs to women for a longer period. And that will be landmark if we can get some best medications that will help these women to, number one, prevent the disease from getting worse and lead to the point where it is quite debilitating, to a point where the women appear to be disabled to even do their normal routine daily activities. That will be very good, and I'm excited that there is signs that these drugs are really showing that they might be at least help us, not necessarily to cure, but to also manage these patients, because they are very effective when it comes to pain and also to limiting the disease from progressing further to cause more damage and harm to the patient.
Dr. David Emvula, it was lovely having you here with us. I hope our viewers have learned as much as I have. Thank you so much for your time this evening.
Thank you very much. I'm very excited to be part of your team today.
Well, there you have it. That was Dr. David Emvula, a specialist obstetrician and gynecologist, speaking to us on the topic of infertility and endometriosis. We're going to take a brief break. We'll be back thereafter.